talking about suicidal ideation and self-injurious behaviors. We're going to cover both the assessment and treatment of both of those topics. And this is just a little bit about me. I am currently in Beacon, New York, so about 75 miles north of the city. It's pretty cold here, but it's also beautiful. We were talking about that earlier. So hopefully some of you have like a snowy window to look out of when you need a break from the slides or the conversation. I went to Boston University for my undergrad degrees. I majored in psychology and deaf studies. So I do have a lot of experience working within the deaf community. That took me to Washington, D.C., where I got my PhD in clinical psychology at Gallaudet University. While I was there, I really focused my experience on working with children and adolescents. So I worked at Kennedy Krieger Institute at Johns Hopkins in their child and family therapy clinic. That was a lot of functional family therapy. I did Children's National Medical Center, working in a mood and anxiety disorders clinic, so a lot of exposure and response prevention. And then amongst some other trainings, I took an extra year to work at Newark Beth Israel Medical Center in their child maltreatment unit. So a lot of experience with trauma-focused cognitive behavioral therapy, again, both assessment and treatment, working within the foster care system. And then I came back home to my area, this area where I kind of grew up in Poughkeepsie and Rhinebeck. I worked in an outpatient clinic for many years. A lot of my experience is really hospital-based outpatient clinics, worked as a residential treatment facility, and ultimately my experiences and then became sort of my passion in this field was working with adolescents and young adults who were presenting with anxiety and depression, but also had a history of or were actively experiencing suicidal ideation and self-harm. I have some experience in family court. I currently have a private practice, BFF therapy in Beacon, and I push into schools as the psychologist for this not-for-profit, James's Warriors, which started here about 5 years ago, doing assemblies and trainings and presentations for students, staff, and parents on youth mental health and suicide prevention. So this is something that I'm working with, whether it's pushing into a school, at my private practice office, consultation, or just writing about it really every day. So I'm really appreciative for you guys to just join me and be part of this conversation. So what brings us here today, right? Like let's ground ourselves in where we're at. The CDC does run data every few years, so it's not published every single year. Most recently, they have 2022 data. So over 49,000 people in the United States died by suicide, roughly a stadium full of people for visual. For my population and maybe for some of yours, the second leading cause of death for children ages 10 to 14 years of age. I tend to work mostly with high school, college, and like early career individuals, but I'll get the occasional middle schooler as well who is, really struggling and has some experience with suicidal ideation or self-harm. And for that population, a little older, it's the third leading cause of death when we're thinking about individuals aged 15 to 19. So we'll talk a lot today about how to adapt, modify, make it developmentally appropriate some of the conversations when we think of assessment and treatment of ideation and self-harm to the younger population. But I'll also talk about what I do specifically if it's not a minor, if it's 18 plus, how I might integrate consents and modify those conversations as well. So just to make sure we're all on the same page, going over definitions, I'm going to, refer to these words. And again, if you ever have any questions or confusion, please put it in the chat, but let's just break it down. When we think about suicidal ideation, I often think about thoughts of death that exist on a spectrum. I say that right off the bat because I think that hearing those words, seeing those words, suicidal ideation, or having a client come in and disclose that they're feeling suicidal or have some passive thoughts can feel really scary. And that's absolutely valid. Like that is a scary disclosure to have come into the room. especially if you're not expecting it. But to remind yourselves and to remind your client that those thoughts do exist on a spectrum. So just because someone has recently had or even is actively having some thoughts about death, there's a lot of assessment that needs to take place because they don't automatically qualify as eligible for an inpatient unit or a higher level of care. So thinking for yourself about this spectrum, I've had clients for close to a decade at this point that experience passive ideation every single day, but there's no intent, there's no plan, there's never been any letter writing. Like they have resources and skills and people in their life that will ensure their safety. And they know if they start to feel like they're in a crisis or that they can't keep themselves safe, they know the steps to take to reach out for support. So when you think of passive ideation, it is this desire to take your life without a specific plan or intent. Actively does include a specific plan. That is where you start thinking about higher levels of care. When we talk about self-injurious behaviors or self-harm, that's deliberate behavior resulting in the potential or actual injury of oneself. Non-suicidal self-injurious behaviors, so NSSI, non-suicidal self-injury, is considered a significant risk factor for suicide attempts and death by suicide, may or may not accompany suicidal ideation, but it is without suicidal intent. So that's sort of how we differentiate them when we're thinking about, disclosures that are made and what the next steps might be. And language matters. I mean, you see on this last slide under NSSI, we talk about death by suicide, right? Previously, someone might say they committed suicide. This client committed suicide, and that commitment, it implies sin, crime, it pathologizes those that are affected, and really in no other instance of death is blame placed on the person. And to those with suicidal ideation, this language can contribute to really immense amounts of shame associated with having these thoughts. Like they're not asking to have these thoughts, floating around in their minds, and might prevent them from seeking out help because of this perceived but real stigma. So more appropriate terms rather than committed suicide would be died by suicide or completed suicide. Of course, I might use a client's language first just to match where they are, but then I will, moving forward, just use my own language. I might not necessarily give them a lesson on it, but hoping that my use of the more current updated terms sort of models for them alternative ways to say it that don't pathologize as much. Going back to 2021 CDC data, and this is more relevant for the minor population, but 22% of high school students that they conducted an assessment for had seriously considered attempting suicide. 18% of those students had made a plan, and 10% of them attempted suicide one or more times. So again, this is very prevalent, especially if you're working with younger populations. 3% of high school students made a suicide attempt that resulted in an injury, poisoning, or overdose that had to be treated by a doctor or nurse. And then there were some trends that emerged from the CDC sort of assessment. Female students and LGBTQIA plus students were more likely than their peers to experience poor mental health and suicidal thoughts and behaviors. Hispanic and multiracial students were more likely than Asian, Black, and white students to have persistent feelings of sadness or hopelessness. And we understand hopelessness to be a significant risk factor for suicidal ideation or urges to self-harm. Black students were more likely than Asian, Hispanic, and white students to attempt suicide. And while the percentage of Black and white students who attempted increased, the percentage of Asian students who attempted suicide decreased. And the percentage of Hispanic and multiracial students who attempted suicide did not change. So to talk more about risk factors, think about for me, things that I might want to be paying attention to from sort of the very first consult call. Um, for me, because I do see a lot of adolescents, but even young adults, sometimes caregivers are calling me to set up appointments for their college age children. Or if a young adult is having a really hard time or their anxiety or depression is preventing them from sending an email or making a call, even like early individuals in their early 20s. These are the questions that I'm paying attention to. These are the questions that I'm going to sort of design my intake around. A form that I'm going to send to these clients so that they can fill it out, just so I have a general sense of what's going on. And then this will also guide my initial intake and, conversation through the early sessions, just so I have a better idea, even though I'm going to conduct a risk assessment from the very first session. And because I specialize in high risk presentations, a lot of clients are coming to me or being referred to me because they are struggling with ideation or urges to self-harm. But these are the things that you want to keep in mind. You want to keep in mind family history, family mental health history, but also family history of suicide, the ideation of it, any self-injurious behaviors, any like existing plans or notes found, any attempts and the outcome of those attempts, any history of adverse childhood experiences. And for me, because again, I'm working with minors a lot, I want to be mindful of ACEs within the entire family because I understand ACEs impacting caregivers to also impact the children in the home. Any prior attempts for the client themselves, what happened, higher levels of care, what were the interventions, previous history of therapy, any substance use, any co-occurring disorders. When I think of unemployment and marital difficulties and financial distress, I'm thinking about the whole unit. So if it's a minor, but also if it's a little bit of an older client that still lives at home or has a really close relationship with their parents and might be impacted by unemployment, marital difficulties, or financial distress, I think it's important to really understand the system in its entirety. So not just client unemployment, client partner or marital difficulties, client financial distress, but like, is the home environment also experiencing some of this distress and difficulties? Do they have the social support? Is that a therapist? Is that a group of friends? Is that one really, really good friend? Is it a teacher? Is it a coach? This is going to be helpful in me just understanding their sort of support network, but also when I'm thinking about safety planning, if that is needed later on in the session or during an exposure, who are those people that I might be able to bring up if they can't in that moment think of someone that might be a trustworthy individual to include on their safety plan. Being mindful of cultural barriers, just like area barriers. If it's a small town, they don't necessarily have higher levels of care. I'm in the Hudson Valley. I'm in Beacon, but I'm pretty close to Poughkeepsie. Luckily, in some ways, I can say, yes, we're lucky that we have a stabilization center, which is open 24 hours a day, 7 days a week, connected to a hotline for anyone experiencing a mental health or substance use crisis. They can call or text 24/7. That connects to the stabilization center, which, depending where you're living in the Hudson Valley, is around 30 minutes. You can go there for an evaluation and they can hold you for up to 24 hours. And we'll talk about the data on timing and how important that is and how 24 hours can really be the difference. Unfortunately, if you work with youth in this area, the closest higher levels of care for them in terms of residential treatment facilities or inpatient units are at least 45 to 60 minutes away, like Four Winds in Katona or Westchester Medical Center. So we need to be mindful of access to healthcare, access to higher levels of care, what it might be like for a person in crisis to get themselves to a higher level of care, or a person in crisis having their support network transporting them to a higher level of care. And then the most important risk factor that we'll talk about later is access to lethal means. So we'll talk a lot about deliberation data and means restriction as like one of the primary goals when you're thinking about safety planning and maintaining like safe treatment. Some notable changes that you might notice in a client that is coming to you for a while and feeling kind of stable, but you're noticing little nuances, or maybe a caregiver or a client is calling you saying these things have been happening recently, and I feel like it might be a good idea to meet with a therapist just for monitoring. Might be school attendance and performance, same thing for work. If you're previously able to just like get up and go to school, go to work, maintain your day, versus like showing up late, having to skip classes or skip meetings, having to leave early, all of these different things, being able to do things on deadline, being able to perform well on tests, withdrawing from relationships, peers, teachers, bosses, colleagues, sleep patterns and appetite, whether that's feeling like you are no longer hungry and no matter how tired you feel, you can't fall asleep, or no matter how much you eat, you're never feeling, satiated and you can sleep all night and still wake up, not rested. Having excessive worry, feeling mood shifts, increasing in substance use, somatic experiences. So a lot of my clients do have headaches or stomach aches, a lot of GI distress. I'm collaborating constantly with GIs and neurologists. I do a lot of chronic pain work because I have a lot of clients that do, manifest their symptoms somatically. So I use a lot of pain reprocessing therapy in my work. Anhedonia, so loss of interest in previously enjoyed activities, feelings of hopelessness or unworthiness. These are more, classic depressive symptoms, preoccupation with themes of death. And that can be someone who is, leans more anxious and just finds themselves preoccupied with death as the theme, but also just in general, even if they're not typically an anxious person or a person who ruminates often, but is starting to read about death and mortality, drawing art, looking at art, collecting pictures that might feel a little bit more morbid, planning out their own funeral, that ties into like writing notes, writing eulogies, all different types of things. If they are talking about, death often, and that connects to the last thing, which is lack of interest in the future. So feeling like nothing is worth it because what's the point? It's not like they're going to make it through the week or the month or high school, or this job doesn't matter because it's not going to lead to anything. Like they don't see themselves even getting to that point in time. So what's the point in talking about what happens next or what could happen next, how things could turn around, like setting goals for a life worth living, if they can't do that, and then there's a lack of interest or even like a true barrier to visualizing or thinking about that part of their life, then that's a significant change, a big risk factor. And I see that a lot, especially in my older adolescents who are sort of in that transition period of either thinking about what they're going to do post high school, or if they decided, to go to college, what they're going to do post college and enter the real world. So I think it's really important to normalize the conversation. That's a big driving force behind James's Warriors, that organization that pushes into schools, because there is this commonly held stigma that talking about or inquiring about suicidality increases suicidal tendencies, but that is just not what the data suggests. A literature review between 2001 and 2013 examined whether that inquiry induced suicidal ideation in adults and adolescents, and that was within both general and at-risk populations. None found a statistically significant increase in suicidal ideation among those participants that were asked about suicidal thoughts. The findings suggest that in both populations, acknowledging and talking about suicide, in fact, reduce rather than increase suicidal ideation, and that repeat questioning may actually benefit long-term mental health. And this for me comes up a lot, makes me think of my clients, my families, because often when there's been a disclosure, and even if there hasn't, but the caregivers or whoever else, a partner is in the home and is really worried that like the next step or one more crisis will spiral into suicidal ideation or self-harm, they're constantly checking in on the client. What was your day like? What's that face? Why are you so quiet? Oh, you took in a deep breath. Anything could be evidence to them for concern, for significant concern. And then they're asking, asking, asking. And for the client, that feels really annoying and makes them sometimes want to like shut down the conversation altogether. And so I think it's worth having that conversation be brought to the table because it's happening often. Like it's even something I might bring up even if they don't, because I'm going to expect that something like that might happen, and best to just put it out there to normalize the conversation of, yes, you are seeing these things, you're extremely worried about this person because you love this person and you want to make sure that they're safe and supported. And of course, that's so amazing to have a person in your life that is like cares about you like that. And as the person who's struggling, it can feel like a lot to not be able to breathe a little bit differently and have someone like breathing down your neck. Are you okay? Like, are you going to hurt yourself? When, they might just be thinking about the ending of a TV show they watched that they felt disappointed about. So, trying to figure out both in frequency and language that works for all parties, how to ask about it, how to check in so that they don't feel like they have to ask all the time because you're sort of giving them some information, but also giving some psychoeducation that the repeat questioning does in fact help. So not taking either side, but giving them all of the information. I think it's really important to be transparent in the room from that first call, certainly from that first session, and breaking down those limits of confidentiality, right? Saying if you are having thoughts about hurting yourself or have taken action that has caused you harm, this is what's going to happen. Be upfront exactly what will happen if they do disclose self-harm or suicidal ideation. And if you can, sort of get their nod or their verbal okay before moving on. Say something like, I will not end the session until, if it's a minor, your caregiver is aware of what's going on. We've agreed on a safety plan for in between sessions. Knowledge is power. Give them as much information as they have. I know some people might say, well, if they know that this is what's going to happen next, then does that minimize the likelihood that they'll share in the first place? Possibly. Like, we can't prevent that from being the way that it lands for some, but hopefully you are creating space that lets them know that this is a place and you are a person where this conversation happens all of the time and should be brought to the table. And even if they don't bring it to the table, you're going to be talking about it. So it kind of gives them permission to have discussions about it. And I'd much rather have them know what's going to happen next than have them be the most vulnerable, share this information, and then be sort of blindsided by this is all the things that are going to be taking place next. And, qualifying that for them, reminding them that this is done because you want to make sure that they're safe, as does their support system, and that no one should have to go through these thoughts or urges by themselves. When talking about disclosures, I think it's important to always be prepared, like whether or not that person is coming in with a history of or recent or active suicidal ideation or urges to self-harm. There could be a bad day that just, pushes someone a little bit further than they were expecting, and they start to have these thoughts of, even if it's I want to kill myself, of like, oh, I just wish that I could go to sleep and not wake up. or I just don't want to be here, or it would be so much better if I wasn't here. They'd be better off if I wasn't here. And to validate for you, which I think is such a large portion of why I do these trainings too, to validate as clinicians, it is so hard to hear someone disclose SI or reveal an incident of self-harm. Even for people who do this every single day. Like, this is something that I feel is a skill that I work a muscle to be able to hear these disclosures, to respond to these disclosures, to assess, to work with them. And it's still hard. It's still sad, overwhelming. It can feel scary. And it's normal to feel any one of all those feelings in response. So I really want to normalize that for, people working with these populations or just in the mental health field in general, because at any point someone can make a disclosure. And so the goal is at least right away, making sure the client is not privy to that internal experience. I've certainly had conversations with other clinicians and have thought, done a lot of reflection myself of the benefits of allowing the client to see that it is something that's hard to hear and hard to digest, because it's sort of normalizing, like, yes, this is like deeply painful. Like, I am impacted by you sharing this pain. I obviously don't want you to be in pain, and it makes me feel a lot of feelings to know that you are struggling. And also, I'm so glad that you brought this to session, because we can work together to make sure that you are safe. But at least to start, kind of just listen to them, take a deep breath, nod, say okay, and continue the conversation sort of in a tone of voice as though you were reviewing the grocery list, right? You're not necessarily going to lean forward and whip out a notebook or your laptop and start writing all these things, because you have to do a safety plan. And I know that there are parameters sometimes that you are constricted within. Like when I was working in an outpatient clinic, that was sort of our protocol. If someone made a disclosure, you whipped out the safety plan, and you just were looking at the safety plan, reading questions directly from the safety plan. Didn't matter where the client was sitting, whether your back was to the client, you had to sort of be turning back and forth. You had to be answering and filling out that safety plan before they left. And I will still do that. I'm going to work on a safety plan. I'll complete it. I will have them a copy to them by the end of the session. But I think that there's some organization tweaking that can be done in terms of the steps that we do these things. So I'm nodding, I'm saying okay. I'm just talking to them as though, we were talking about anything else. And it is really important, again, when we think about somatics and just like the body responding to something like this, be mindful of your nonverbals, because even if you've mastered this initial verbal response, you might be holding tension in your body and they're going to pick up on that. So some people, might take in that deep breath, might be holding their breath, might lean away, might cross their arms, might cross their legs. It's a reflex, and that's okay, right? Super valid. I want to, again, remind you guys of all of that. But this is tough stuff. So that's why the body is going to respond like that. And by checking in, you can just be aware of that and maybe loosen up a little bit, uncross your arms and lean into the conversation. Let them know that you are still with them in the midst of this tough conversation. Why is all of this important? You have to think about what the client's going through as they're silently deciding if you're even a safe enough person to share this information with, right? They may consider this a risk to the relationship as it previously existed. This could be a person who you've only known for 1 hour or for 10 years that is trying to make a good impression on you, or is worried that, the dynamic that you've curated over months or years of work together is going to shift. And change is hard, especially when you are, having this much distress. Like familiarity is comfort. And so they're having to decide. They're thinking about this probably well before they actually make the statement to you in session. If they're a minor, hopefully they remember once they do share with you, it won't be their best kept secret any longer, because once they make that disclosure, they know it's going to be shared with people they live with. And for whatever reason, those people might not know. You could be the first person that they're sharing this information with. And it might be, part of their plan to say, okay, well, I'm going to tell Jamie, and Jamie's going to help me tell whomever is in the waiting room or waiting out in the parking lot, or, who she has consent to call and make sure everything is safe at home. These are real, like, reported experiences of people that I've worked with that have explained what it's like for them behind the scenes prior to making a decision to disclose or an actual disclosure. And it could be one of these feelings, it could be more, it could be all of these feelings. They feel embarrassed that they engaged in self-harm, and so that can be hard to disclose. They feel really frustrated that they have suicidal thoughts, like maybe they're around other peers or partners that might struggle with some anxiety or some depression, but don't have thoughts specifically around death or harm. And they're upset that they happen to be a person that experiences those thoughts. They're sad that they have urges to hurt themselves. They're nervous or scared about how you or other adults in their lives might react. Even if it is an adult client, how a partner might react. And determined to keep this between the two of you, even though as a minor, they know that the next step at some point during that session is to inform a caregiver or someone that's at home, a guardian, about what's going on so that they can be looped in and part of the safety planning. And by reacting in this sort of matter-of-fact, non-judgmental way, you're communicating, one, this is not the first time you've heard something like this. That can really help. I kind of give them this information when I'm talking about myself and who I am and what I do, even if there's not been a disclosure, that I can handle hearing something like that. That it's not going to change my view of them, that I'm not immediately going to like pull in a caregiver, that I'm not automatically going to call 911 or send them to a hospital, that my perception of them is unchanged, and that I'm a safe place. And that talking about what I call the tough stuff is why places like this exist. Like, this is what I do. These are conversations I have every single day. That can be really comforting for them. Chances are they've received messages outside of the room that this type of conversation is too much or worse, off limits, whether that's their own personal experience, trying to talk to someone who said, oh, I don't want to, don't tell me this, or I don't want to hear this. You should go to this person, this guidance counselor, tell your parent, like tell this coach. Or, wow, that's a lot. Like, I don't really know what to do about this. And not really referring them anywhere else, but just being like, whoa, like we need help, but that's it. That could be their experience. It could be a friend's experience. It could be a family member's experience. It could be something that they've seen on a TV show or read in a book or a movie. So they're coming in with like a lot of this external baggage. And they may have also been met with these nonverbals, these unhelpful statements that include things like, whoa, okay, wasn't ready for that. Or, oh my God, what? That's so awful. Why would you do that? Like, why would you hurt yourself in that way? Or I don't know what to say, what to do, how to help. Yeah, someone said, I've had an experience of a client being threatened to be kicked out of the home due to SI and cutting. And I mean, just when you think about that, and I feel so much for that client, how that impacts their decision making about sharing, even if they've identified that this is something that they're experiencing that's really painful for them and causing them distress, and they want to tell someone about it because they want to make sure that they're safe and like have resources to manage this thing. But by doing that, they're also like putting themselves at risk and, potentially out of the home. It's a lot. This is a lot of stuff that they're having to manage. Yeah, if you respond similarly to these things, right, you're only enforcing their initial fears. So we've gotten to the big three. Let's start, we'll start here and then we'll kind of move into our first break in a bit, but let's talk about risk assessments. Um, Again, as I mentioned earlier, a risk assessment should be conducted at intake with all new clients. I think that's important for all, clinicians. I think that's been drilled into me as like a high volume hospital-based outpatient clinic gal, but also as someone who specializes in high risk clients. It's just mandatory from my perspective, like with the clients that I'm working with. But I encourage you at least to just integrate these questions into your first experience with the client. And I do this a little bit with consultation calls that I might have before, because sometimes I'm trying to figure out where and if I can fit a client into my schedule. And if a client is suicidal or actively self-harming, I'm going to see them every single week. And so I need to know before I like, make all these promises to a family or a client, bring them in on a spot that's only every other week, or I have no weekly appointments. I need to have some information about this. So being direct, again, that taps into just directness, transparency. Have you thought about ending your life? Do they have a specific plan, right? Number one of the three. Questions like, when you think about it, what do you imagine? Is there a specific method you have in mind? Number two, access to the means. Is there access to the means involved in their plan? So if they've identified a plan, you move on to the access. Okay, what are these objects you're thinking about? Do you have X? Do you have this object? Where is it located? Is there a lock? Like, is it accessible to you, even if you know that it's there? And number three, intent. Is there any intent to act on that plan? So this is just all important information, certainly to decide level of risk and whether or not you need to be starting to think about coordinating higher levels of care. And also as you're monitoring time of session, where you are in the session, and this will come up a little bit later, but just thinking about, I book clients after school hours, after work hours, back to back. So typically there's a person waiting in the waiting room by the time, like 15 minutes before my last session is even over, and we kind of like swap out. I need to be mindful if this is something that requires coordinating higher level of care, how to proceed with my subsequent sessions. When I think about intent, you can ask, have you done anything in preparation? You can use likelihood. You can use a Likert scale, right? On a scale of 1 to 5. What is the likelihood that you will, pursue this action, look for this object, obtain this object if you don't have it? You're just trying to gauge information, build insight for you, for the safety plan, for coordinating higher levels of care. These are the big three. Whether it's thoughts about engaging in NSSI, and that's cutting, burning, scratching, snapping. Some people ask about snapping. A lot of clients might use things like an elastic or a rubber band. Sometimes elastics come with like a little bit of a metal section, or a section that's like a little chunkier than the rest of it. And by like pulling and snapping, whether it's once really hard or repeatedly, it stings, it can cause welts, sometimes it can break skin. So it's an action that's done with the intent to cause harm to oneself. Or suicidal ideation. These questions all remain appropriate. And again, this is just building insight. I have yet to break out my laptop. I don't have a notebook with me. I'm just having a conversation about these things. I'm doing so with the intent to collect the information that I know is going to go into the safety plan, but I'm not filling out the safety plan while I'm doing this. I am with the client. I am leaned in. I am nodding. I'm doing active listening, and I'm asking these questions. When did it start, right? Are the thoughts connected to something that happened recently? Is it a response to something that's happened previously that they were reminded of? Something someone said? How many times has this occurred? It doesn't matter if it's only occurred once or many times. That insight of certain settings, certain times, certain people is going to be helpful information. And then what reduced the intensity, frequency, and duration, another big three of those thoughts. How intense, how overwhelming, how severe they were, how often they're happening, and how long when they pop up do they experience sort of this intensity of an ideation. And how did they cope? What are the tools and techniques that they use? Whether they refer to them as coping skills or not, maybe they have no history of therapy. What kinds of self-soothing tools are they using? Who are they reaching for? And then the secondary follow-up to that I think is so important that we don't always say out loud is, okay, how did they cope? What skills do you have? Do you have a toolbox of skills? How effective were those skills in maintaining management of those thoughts? Because I can have a client who comes into my office with 10 years of therapy experience and can list off it beautifully the entire distress tolerance section of the DBT manual. But when they're feeling that overwhelmed or start to feel suicidal, they have zero access to those skills. They can maybe see them, they might be able to list them, but maybe not. It could just be a cloud of distress, and to use cognitive skills to see it, select one, pull it out, use it, and use it effectively, that's a lot of work. We're putting quite a bit of pressure on a person who's just trying to stay safe. So I always want to follow up on, okay, what are the things that you use to cope? How did you cope? And when you tried to use that skill, did you have access to it, and did it actually help? There's an app that I recommend to a lot of clients that's mentioned a little bit later that we'll get to, that does a check-in after they provide these skills, hey, how did that go? Did you feel like you could even utilize it? Did it feel effective? If not, here's another list of options. So I'm a really big fan of that. Just because having suicide, just because they're making a disclosure, right, doesn't automatically mean they're in immediate danger. And this goes back to slide 1 of these thoughts exist on a spectrum, and you want to give them time to think. This might be the first time that they've shared this information, and could be certainly the first time that anyone's asking them detailed questions about this experience. So giving them space, telling them there's no pressure for a quick response, just being quiet, and maybe to make them more comfortable, and you can gauge person to person. I have a general sense of which clients are going to feel a little less pressure if I do not maintain eye contact with them, or if I start playing with a fidget, or if I'm looking at a pillow. I'm giving them the space to figure it out. And for you all to be prepared for I don't know as an answer, and honestly to say to them, that's an acceptable answer. Listen, I can recognize this is the first time that you're talking about this with me, but also maybe with anyone. I have a lot of questions that I want to make sure we get to, just so that we can start, end this session feeling like the things we do know we can work with. And if we need to gather more information, we have a plan for that before the end of this session. But if I ask you a question and you don't know, that's fine. Just say, I don't know. We'll figure it out together. And I think that's humanizing for us as clinicians and pretty normalizing. I think it again helps you like meet the client where they're at in that moment. Because as a provider, I don't have all the answers all the time. Clients ask me questions sometimes, and I'm like, I don't know. I have no clue. I'll look it up. Or let's look it up together. Or, oh, I'm thinking about this one book or this one thing, but honestly, I would be making it up. Like, I need a minute to figure it out. It would be unfair to expect that they have all the answers for all of the things and let them know that, vice versa. We're sometimes going to say, I don't know. We'll get to it together. Both is okay. When you are building insight, you want to be clear, you want to be concise, ask step by step. And, questioning, use language as starting point, like their specific language. And as I mentioned before, it's going to be helpful to clarify these details before creating a safety plan, bringing in a caregiver. Sometimes when someone is saying, I don't know, I don't know, I don't know, especially if you're working with teenagers or young adults, they do know. They've given you information in the past that is answering your question. And it might be a decisive sort of resistance to proceeding with the conversation. Also, they might just not have access to that response in that moment because they're so overwhelmed with the conversation. Again, this is tough stuff. But read the room. Sometimes I might push a little if they say, I don't know, I don't know, I don't know. I might say, okay, it feels like, this conversation is hard. It feels like there's maybe some barriers to talking more about it. Are there things that we can change about this conversation or even this space? Like sometimes I'll have a session in the dark. Like I have little lights that glow enough so that like it's not pitch black, but sometimes people don't want to see me when they're talking about this stuff. And that's fine. They're right in front of me. I can basically read what I need to read. I'm hearing them. If they need to turn off the lights, then let's turn off the lights, but let's figure it out. So I might push a little bit. Like, are there things that I can do to make this conversation a little bit easier for you? And also, you're saying you don't know, but earlier you mentioned that this person or this class is just like the worst part of your day. You have a hard time going. You often skip when you're there. Like you start feeling really antsy. You might panic. You have to leave anyway. Like, how does that sort of tie into these questions? But ultimately, I don't want a client leaving the office more stressed than before they came in. And so you have to just use your best judgment. And as I mentioned earlier, think about how long into the session you are. I'm booking the hour. Sessions are typically 50 minutes, but again, they're back to back. So, like, do I need to say, hold on for a second? I want to give you as much time as you need. I just need to let my next client know that we're going to be a little late or I need to reschedule. That way, like, while you're in the thick of it, you're not like, oh, let me just quickly like walk outside or someone knocks on your office door because it's time for their session and you're sort of like interrupting. You can find times sort of like to weave in, that I book back to back. I just want to make sure that you have the time that you need. And I also want to be respectful for the next person. So let me just send them a quick text or an email to let them know that something came up and I need to postpone or reschedule. And then you can go back to it. And then they know that they have your full intention. They don't, you don't want them looking at the clock being like, I know I'm almost out of time. Like, I don't know what to do. I have more to say. And they leave things out or they cut themselves off or they lie because they want to just like wrap it up. They have my attention. This is a safety issue. Let's see what the next line is. Let's take our first break. Does anybody have any questions before we do? Feel free while we're on break to type anything into the chat. I'll be here monitoring it. And then we can get to those questions afterward, but let's come back at 11:04 and we'll get into deliberation data. So let's continue with some of everybody that's back. These questions. Someone asked, how do video games, especially killing video games, affect a child or adolescent inclination to self-harm or tolerance for non-preferred activities, challenges? I think I don't know the data or statistics on the inclination to self-harm, but I do know that there has been some research that shows that those types of video games desensitize violence, desensitize um, gore, blood, things that in the past may have postponed or redirected an individual's thought process from something that caused harm, that caused injury, that caused blood. Um, but the exact data I'm not sure about, but I do know that there's certainly been some desensitization that absolutely, in my opinion, could be leading to self-harm in particular as a potential option when it wouldn't have been in the past. No problem. Let's keep going. Someone asked, can you talk about how to assess teens when they have a friend who recently completed suicide? So tough. I don't have a specific slide on this for today, but it's certainly worth talking about. I often talk with my teens about what like seeking support for themselves when a friend of theirs expresses suicidal ideation or shares self-harm because they often approach them like that individual approaches my client with I have to tell you something you can't tell anybody else, like you have to keep this a secret, and that is so much pressure for my client and then can lead to overwhelming thoughts and feelings for themselves and then domino effect, so it goes. So talking to them or creating space for them to bring up in session that they're not having these thoughts or feelings. This comes up too when I'm doing assemblies in high schools. If they don't particularly relate to it, but they have a friend that they're worried about or has come to them, and helping them to understand, empower them to, make this reframing statement to the friend of like, I'm here to listen to you and to support you. And we need to bring this information to an adult. Or here are the resources that we can use to connect you with the stabilization center or mobile crisis or something like that. Here, like, let me call the number. Like, I can share that information for you, or I can be with you supporting it, supporting you while you're doing that information or sharing that information. So that can be really helpful and normal experience for a lot of high school students, college students. When they have a friend who has recently completed suicide, I think, of course, it's, worth talking about and again, normalizing the conversation, bringing it to the table, letting them know that they have permission to talk about it, validating that painful experience, and again, being transparent, being direct. Have you been thinking about suicide? Have you been thinking about suicide as it pertains to you? Like, let's talk about it. What are your questions? Are you struggling in this way? Like, have you been struggling in this way? Just again, bring it to the table. So I think that's part of the assessment is just like normalizing the conversation and giving permission to talk about it. Someone is just validating that the I don't know awkward pause answers are very awkward, and they certainly are. I feel like I had like whole classes in grad school where we were just like trained to tolerate silence. So I think, I mean, I appreciate an adolescent attitude. I really do. And that banter that we can get, one of my favorite things to do. But I do have this tolerance. If they think that they're going to like quiet me into submission, they will not. So it's kind of, awkward silences are kind of fun for me. And I think that is something that can be an indication that this is a population that might be really good for you if you enjoy it. But also validation that even though it's fun, like it's not easy to just sit there and like hold out and be the one, even especially if they have like given information before and now they're sort of I don't knowing you, versus actually just saying I truly don't know, but certainly validating that can be really awkward. Someone asked, and I tried to clarify, so I'm just going to say it out loud and hope that, if there's additional questions, feel free to type it in the chat. They were asking about a framework, and I think more like the organization or the typical order of ideation when it comes to suicide or self-harm. They said it's the ideation, the plan, and the carry through. That typically is the order in which things happen. Like they are thinking about it, then they think, okay, if I would do it, how would I do it? And then they think, okay, I'm going to do it. And also, I don't know that there's like a guaranteed 100% for everyone order. I've certainly had clients that have come in and said that they were just like going about their day. Maybe they were feeling super anxious or dysthymic, or it wasn't a great mental health day. And they were driving in the car and they just thought to themselves, what if I drove off the road and like into this ditch and died? Or what if I just drove into oncoming traffic and died? So they weren't necessarily thinking, oh, I'm feeling so overwhelmed. I wish that I could just die. I'm in the car. I could drive into oncoming traffic. It was some sort of like an impulsive thought. And we're going to get into that right after this with deliberation data, and intrusive thoughts and the timing of that all. But I do think typically it follows the ideation plan carry through order, but it can just be sort of like a thought that pops into their mind, and that thought could be the plan first. So ideation and plan can sort of happen at the same time. Okay, multiple people were wondering about how I would handle the situation if the session was being held virtually, and that's a great question. I do sort of have a hybrid model. I do see many of my clients in person, but I do have some virtual clients using teletherapy, and I'm always ensuring at the start of the session that I know where they are. Like if it's not a background I recognize, I want to make sure I know where they are. I want to know who is like home, who is around. And I am always ensuring that I have communication access and permission for those individuals that are around. So like whoever typically lives with them, I have consent to speak with them, whether it's because it's a minor or I've obtained consent for an 18 plus client. And then I have their contact information, both email and like phone number. So if I need to bring a caregiver in, I can like text them or email them and say, okay, please join the session at this time. Or if the client feels able to, just like shouting like, hey, come on in, like Jamie wants to talk to you. But I'm making sure I sort of have my bases covered at all times with virtual clients. This also comes in handy too when you find yourself like in a mandated reporter situation where you just want to know like who's home, like where they are, what the address is, what's the best phone number to reach the client, what's the best phone numbers to access those individuals, whether they're caregivers or partners, family members of the client, to keep them safe. Also, in terms of address, it helps you sort of coordinate where are the resources that are local to them if they need to be referred to a higher level of care. But otherwise, I'm sort of maintaining the same thing. I'll stay with them on the computer or on the phone, just like I would in a session. And I'm asking them a lot of the same questions. Is there a disadvantage that sometimes I can't like watch their leg bounce? Maybe a little bit, but you can see it. So you're paying attention to sort of those nonverbal cues. This came up multiple times also. I wonder if immigration status of family or client plays into the conversation around safety planning. Most certainly. That's also, when I think about lack of access to healthcare and barriers to treatment, something I want to be paying attention to from, the intake on, and also, feeling lucky that there are places, close to me, like the stabilization center, where they're just going to go in and get an evaluation. And they might not have to go through the same paperwork procedures that like a hospital would. Some also people also brought up when the disclosure comes up, right at the end of session, a doorknob confession, very frustrating, absolutely. Someone said I'll usually delay the end to inquire in that case, and I agree. That would be a circumstance where I'm going to say, oh, come here. We need to talk. I have a couple questions for you. Um, thank you for sharing. Let's talk about it. And I might just like you head back into my office, and I'm gonna go into my waiting room and be like, I just need, I'll be back in a second, just to, like, update you on what's going on. But yeah, I'm gonna risk assessment right there. I'm not gonna let them go home if they're making a disclosure. Um, and that's, you want to have empathy. Yes, it's frustrating, and you want to have empathy and compassion for those clients, because up until this point, everything that we've been talking about, right, is highlighting how difficult this disclosure is for them. And so, of course, they want to try and say, like, okay, I'm going to build myself up. I'm going to tell Jamie. I'm going to tell Jamie during this hour. Okay, we have 40 minutes. We have 30 minutes, 20 minutes, 5 minutes. She's standing up. I have to tell her. I need to tell her. I promised mom I would tell her. I promised my best friend I would tell her. And then that's it. They make the statement, and you just validate that they did, and move on from there. When seeing adult clients via telehealth who are disclosing passive suicidal ideation, is it clinically indicated to complete a safety plan? That's a very good question. I think personally, I'm gonna safety plan. Whether it's like a formal safety plan, and we'll talk about safety planning in terms of liability, and that it's a step and not just like a continued active process. Like, what does safety plan completion mean to you and like mean to others? I think it's still important to do the assessment, ask about, when they're disclosing passive suicidal ideation, it might not be clear that it's passive when they disclose. So you need to figure that out, and ensure that whether it's an older client and you just want to check in about the safety plan and say, do you have access to your safety plan? Do you need me to resend your safety plan? Let's update the safety plan, versus like, okay, let's go through and do this entire safety plan right now, I think is sort of case dependent. But it's certainly something that I think is clinically indicated to at least initiate, and then from there determine, what safety plan completion means for that client in that moment. Let's see here. What if a client tells you they have a friend that's suicidal, but your client does not want to tell anyone? I don't think there's a legal obligation on our part to ensure that child is safe. That child is not my client. Ethically, you again, case by case, and like your own perspective. I'm just gonna quickly address something else. Someone is asking about safety plan templates that will be provided to you as a resource as part of this training. So we'll go over safety plan development, but you'll also get a copy of the safety plan from me as part of this live experience. But yeah, I think my work tends to focus more on being there for the client who has a friend that's suicidal, who shared that information with them, or who they're worried about, and really trying to ensure that your client is supported. And ensuring, trying to find out what the barriers to sharing that information with someone else are. Like, what are the parameters that would allow for your client to feel comfortable telling one person, identifying who that one person is, so they don't have to handle it on their own, so that they can have support in getting help for their friend. Like, there's a lot of ways to like continue that conversation, but first and foremost, you want to support that client, and then sort of break through, understand, validate, break through those barriers, and identify like one opportunity for them to like partner with someone that can do it. And ultimately, if they're really afraid and they don't want to tell anyone, like specifically, but they're worried about their safety. Like they could prompt a wellness check. But then there's all kinds of conversations about what that leads to and how that would ultimately support the family who needs help. Um, let's say, yeah, someone is saying we're mandated reporters. So yeah, that falls in line with like imminent harm perpetrated by others. But yeah, you could do a wellness check on your own. Um, thoughts on documenting with clients who are chronically suicidal? Yes. Every session for months. I've been working with a client for almost a decade, and she is chronically, passively suicidal. Like it is a thought that exists in her brain every single day. She has no intent, no plan, no intent. Like she is safe, but I ask about it every single week and I document it every single week. And we'll talk about documentation for sure. Okay, we have some we have some anecdotes, so we can get to those in a little bit if there's time, but let's get into the safety plan is sort of a catch-all because I think the information that should be collected and provided is pretty similar. But yeah, I use it with both. Okay, let's move forward on deliberation data. So there is strongly felt ambivalence reported during deliberation on action, right? With competing wishes to die and to live. And research shows that the interval between deciding to act and attempting suicide can be as short as 5 to 10 minutes. So studies found that between 24 and 40% of decisions were made within 5 minutes of the attempt. So that's like to speak to that framework that somebody mentioned earlier in the chat, like thought, plan, action, can be as short as 5 to 10 minutes if you're going all the way through those 3 steps. And that's where means restriction is one of the most important parts of safety planning. And between 44 and 74% of decisions were made within 10 minutes of the attempt. So what does that mean for means restriction? Reducing access to lethal means is considered best practice and consistent with several theories of suicidality. Documentation suggests that few clients endorsing suicidal ideation are being counseled to remove or restrict access to lethal means. So that's a review of clinician documentation. Does that mean that there is no counseling? Not necessarily. To some of the earlier questions in the chat about documentation. Sometimes clinicians do things in session they don't document, but especially in these cases when we're talking about suicidality, we're talking about self-harm, it's really important to document everything that you say and do and the client's response for your liability. But it is suggestive, based on a review of documentation, that not a significant amount of people are being counseled to remove or restrict access. And a number of studies have indicated that when lethal means are made less available, suicide rates by that method decline, and frequently suicide rates overall decline. So people tend not to substitute a different method when a highly lethal method is unavailable or difficult to obtain. So they are rigid in their thinking and in their plan. So when they can't access easily or it's unavailable, which is why that access question is important in the big 3, they tend not to like substitute a different method, because when you think about this like 5 to 10 minute window, if they have this urge, they decide to act on it, and it takes them 5 to 10 minutes to even think about where the item is, how they're going to obtain it. Then they find a lockbox, but it takes them, 5 to 10 minutes to try and find a key or do the lock and things like that. And then with firearm storage, we'll talk about that. Like, we're trying to delay the amount of time that the action would require so that ultimately that deliberation data time runs out and they have a moment sort of come down from the intensity of that urge, to take a beat, take a breath, access some different skills, seek out resources and additional supports, and make a different decision. When we think of lockbox or firearm storage, those are lockboxes you can get at Home Depot or Lowe's. They are like numerically coded. Sometimes they have keys. Don't use your garage code. Don't use your, family birthdays, the initials on your, all of your family members. Don't write the code on a post-it that you post on the refrigerator or store with all the other passwords at home. Same thing with a key. If it's a key lockbox, don't put it on like the large like ring of keys that open things. You want to be using a random password. You want to be hiding that key. You want to be changing the password often. You want to be moving the location of the key. And if we're talking about firearm storage, you want to have 2 storage compartments, one for the firearm itself and one for the ammunition. Because if by some chance they figure out where and how to open the lockbox for one part of the firearm, they can't use it if they don't have the ammunition. You don't want to make it easier for them. You want to delay access for as long as possible because the deliberation time is so minimal for such a significant amount of people. Also, my recommendation, if there's a actively or even passively suicidal person in the home and there is a firearm in the home, remove the firearm from the home. If there's access, it is likely lethal. Lots of fire departments and police departments have safe firearm storage programs where you can call them and have them store your firearm. They work a lot within like that mental health community, being knowledgeable about suicidality, and there are like ways that you can sort of sign up for a certain person that can call and have permission to obtain it, which doesn't include the person that you're worried about. And then when you're ready and feel safe to have the firearm again, or you need it, you can access it when you need it. But you shouldn't even be worrying about whether or not a person, if it's at that level, which also at that point, that person probably will be in a higher level of care anyway. But right before and when they return home, there should be no firearms in the home, even if they're not specifically thinking within their plan, I'm going to use a firearm, just because it's one of the most lethal means. Someone said, I feel like safety plans are most effective when someone the client cares about is present to help with accountability. Certainly. And I'll talk about bringing in caregivers for minors, but also what I do with consents for clients 18 and older. That taps into that. Okay, let's talk about liability, and which will tap into some of the comments and questions that have been in the chat thus far. If a therapist becomes aware that their client is at risk of attempting, courts have generally held that they have a duty to take reasonable or appropriate steps to attempt to prevent the client's suicide. Unfortunately for us, there's not a list of actions or interventions which can be uniformly applied in all circumstances with all clients. So they have this expectation of us. They have yet to operationally define what reasonable and appropriate means in terms of our liability. Some of the things that have been commonly reported when, a case like this is involved in the courts are attempting to increase the degree of social support available to the client. So if you hear a disclosure, if you notice these risk factors, if you're worried, there's evidence that you did, which means you have to document that you did, work to increase the degree of social support involving a friend or family member in the client's treatment, which taps directly into the most recent chat comment. Read my mind. Increasing the intensity of treatment. So making sure that the number of overall contact, the number of sessions a week, whether that's from every other week to once a week, minimum, if not multiple times a week. And then you do have to be mindful about how often you have capability of seeing that client. And that might also be an indication, which is the last one, of facilitating a client's hospitalization. Like if they're requiring intensive outpatient or, partial day treatment, hospitalization you're at least having these conversations, you're walking them through it, you're documenting that you did. And also if they're on medication management, right? Proof that you are discussing, obtaining consent, and consulting with the client's prescriber. So all of those things are what have been considered in the past reasonable and appropriate steps in order to prevent client suicide. But there has yet to be an actual list of interventions or actions that they have uniformly applied. So stay tuned, but that does make, our jobs more complicated. The best that we can do is, safety plan to the best of our abilities and document every action that we took and the client's response to that action. Now we're at NSSI. Although relatively unexplored, there have been some studies conducted in an effort to better understand pain and the way pain is experienced through NSSI and the role pain may play in actually reinforcing the behavior itself. So in some studies, people who engaged in self-harm denied experiencing any pain during the action. They may possibly possess unnatural or developed and reduced pain perception, and it may not therefore pose a barrier to NSSI because the act itself isn't experienced as painful. Other studies have found that physical pain elicited by the action might have a paradoxically positive effect by helping those shift away from their emotional pain. And I'll talk about some lived experience of my clients in what the sort of purpose and intention of the urgent action are, and that is certainly one of them. So physical pain is not only tolerated, but might be intentionally elicited as the primary purpose of engaging in the action. So some models of pain, when we think about it, there is no single universal experience of pain, which does make it more complicated, but there's a few effects. Pain analgesia effect, in which little or no pain is reported during NSSI. The possible mechanism of that effect might be through endogenous opioids or endorphins, which can be released following these behaviors and may, in fact, reduce experiences of pain or elicit feelings of euphoria, and therefore that paradoxical positive effect. And so individuals who engage in NSSI might have higher levels just naturally of endorphins, or they might feel an increase in those baseline level of endorphins, which results in this decreased pain sensitivity. Unfortunately, because the research is limited, it's also been inconsistent. So further research is needed to clarify, why this does occur for some and not for others. Then there's pain onset and pain offset effect. So pain onset effect is in which pain is elicited by the action with the potential purpose of distracting from upsetting thoughts or emotions. So even though some might say, well, that doesn't really make sense, pain is upsetting. For them, the pain is preferred over what other thought or emotion they're experiencing. They'd prefer to distract with pain. And then pain offset suggests that those who engage in self-harm may experience a sense of relief during the offset of pain. And that might be that endorphin perspective. It's not the pain itself that regulates the emotion, but rather the subsequent subsiding of the pain. And so there does need to be further research conducted just to figure out these constructs, to explore whether participants are experiencing emotional relief, physical relief, or a combination of both. They both posit that experiences of pain associated with the action may reinforce the behavior because they're serving emotional regulation functions. So I think it's really important as part of the assessment, and again, I have a whole slide about it, to understand the origin of the urge, the intention of the action, because then that will also help not just building insight and safety planning, but in what we can do within replacement therapy. So if someone's making an urge to self-harm, follow up with a couple of questions. Have you thought about what you would do to inflict harm, what you would use? Again, you're talking about means. Where is the object? Do you have easy access to the object? All means restriction. Is there a specific location on your body that you've thought about causing harm? this is just information I'm gathering before creating a safety plan, ties into means restriction. Someone said, I wonder if there's any research around addiction to endorphins. For sure. And like the play of endorphins and endogenous opioids within addiction, like as a diagnosis, certainly. This like can be hard for some people, and I'm open to conversation about it. I have found that it's extremely effective to ask where the harm was done and to see the recent injuries myself. It can be uncomfortable to ask, of course. I'm always uncomfortable asking. And you can ask and they can say no. And that's fine. But then you can document asked to see the injuries, and then I'll explain why. Client denied because X, X, and X. It might be an area that feels private to them. Clients may be causing self-harm on their arms, their upper arms, but also like their upper thighs, areas that are often like on their rib cage, areas that are covered by clothes often. And they might not feel comfortable, but at least you can ask and you can explain why you're asking. And if they don't show you, you can still provide this psychoeducation so they know how to manage the injury. With the visual, you have an idea of depth and the state of the injury at the time of session. This helps you gauge the seriousness of the harm inflicted and alert you if there needs to be an immediate medical attention given to the wound. I'm going to give a quick anecdote. It does get a little gory, so if you need to pause me for a second, I'll leave when I come back to regular conversation. But this highlights the importance of this and why I think this is so important to include when we're talking about this. I had a client who came in to see me at an outpatient clinic. I'd been working with them for a long time. They had some history of self-harm, typically by cutting, but the wounds were typically superficial, breaking the skin, blood, scab, sure, but like nothing that required medical attention beyond just like home care. And the client came in and said, I did a risk assessment. They said, yes, I cut earlier this morning. It was like early afternoon at that point. And I had them walk me through what happened, what they used, how they like maintained the wound, what was going on. And they were wearing a long sleeve shirt. So I couldn't see what was under it, but they said it was on their arm where it typically is. It wasn't much different than their typical cut. There was a little bit more blood, so they had to use like a towel to wrap it, and we can talk about the hygiene of that. But that like it was fine. And so I asked to see it, and so he rolled up his shirt, and it was still like actively bleeding through the towel, and it was like a deep wound that needed stitches and like immediate medical attention. So I, after, wrapping up that session, sent them immediately to the hospital, which luckily that clinic was down the street. So I was able to sort of like bring in the caregiver, coordinate that they went to the hospital. I was able to get, documentation that they went to the hospital, because also you want to be mindful of that too. Encouraged the family to, saw the wound, did some safety planning, referred the client for immediate medical care, received documentation that client met with so-and-so doctor and received stitches and has a follow-up, all wound care, et cetera, et cetera. So those are things that, again, for documentation and for liability, you can include in whatever system you're using. Okay, Quebec, we're not as gory anymore, but whether the injury is first or one of many, they may not be aware of or care about maintaining the hygiene of injuries. Like people are using sharp objects, whether that's a sharp object that's a part of a razor, whether they're pulling from the sharp part of the tape dispenser, whether they're finding something sharp on the side of the road. They're not thinking about the cleanliness of the object. They're not thinking about the cleanliness of the wound. So providing, getting eyes on, but also just providing psychoeducation about wound care, cleaning them at the time of infliction, during the healing process, after the wound has healed. There's a lot of discussion about in the chat about how some people like the mark, and that's, you'll see that on the slide of Drive. It's part of their ritual. They want a reaction, but some of my clients don't want a scar. And if they don't take care of the wound, then it will scar, it will welt, it will be something that is visible. And so working with them on like vitamin E oil or other products that will reduce, the scar visibility are important to just be mindful of and to provide psychoeducation about in that moment and in future sessions, and again, to document it. You also want to assess for accompanying suicidal ideation. Ask if they're having active urges to self-harm in the moment with you. That's a great opportunity to use skills, watch them use skills you've previously used with the client to see if it does effectively reduce the intensity, duration, and frequency of the urges. Also, perfect opportunity to teach them something new. Maybe they don't have access to those skills they used previously, or maybe you're watching them do it and you can tweak it a little bit or just provide something new. And you're always wanting to encourage them to use those skills outside of session. If the urge emerges again, of course, but also just practicing the skills that feel most reachable, because if you are utilizing them when you're not overwhelmed, when you're not in crisis, they're likely to be more accessible to you when you need them in a crisis. So here's that slide that I was talking about, that self-reported purpose. This is things that people have said. They have the urge that, like, this is the drive. This is what they're hoping to satisfy from inflicting harm because they deserved punishment, because they felt really depressed, they felt worthless, because people in their lives are being verbally or emotionally or physically abusive, discomfort in their own skin. Maybe it's dysmorphia, maybe it's dysphoria, and wanting to kind of like punish themselves, punish their skin, or just like wanting to do something to the skin that they're in because they don't feel connected to or aligned with or affirmed within the body, the vessel that they're in, to feel something, right? Craving sensation. And that could be something other than the emotion. Like when we were talking about the models of pain is something else. Maybe they're feeling everything and they don't want to feel anything. And so they're craving numbness. Maybe they're craving pressure. Maybe they're craving warmth. Some people will talk about like blood as sort of a warm feeling that could tap into those endorphins that the research is showing. And to the point of the conversation in the chat, to see something, to have something recommended, like that they can visibly show somebody. So a scab, a scar, blood, just something visible. So based on all of that, I want to find options to replace that action, which won't necessarily fully satisfy the urge. I'm not, I'm going to give them that psychoeducation. I don't want them to be set up for failure. I want realistic expectations, but it might address the urge just enough that they discontinue the action and feel like they don't have to engage in harmful behavior to sort of satisfy that urge. So one of the replacement options I use a lot, drawing on yourself with something that mimics the color and the markings of what you would see and what you could show to other people. So a red tip pen, lipstick, food coloring. I'll talk about that in a second. Those temporary tattoo markers that I have up here, typically the black, copper, red, and pink, are most often the colors of choice because they most commonly resemble scabs, blood, scars. For food coloring, some people just like the look of the blood. So it's not the look of the injury itself or the feeling of the injury itself. It's sort of the cleanup after. So like having the tissue that has some blood on it. So working with them, I always have all of this in my office to send home with clients, but also to try in session to see what works best. But pinks and oranges and yellows and red food coloring that you can like blot on a tissue so that you can hold the tissue and see, okay, this kind of looks like blood. I know it's not my blood, but like, does it like script? It's just enough that I can take a deep breath, redirect my attention to one of the skills or one of the resources or a person of support to help me beyond, inflicting harm. Temporary tattoos satisfy that same need for touch, texture, visual feedback anywhere on the body. So I always have temporary tattoos in my office. If I know a client is sort of like in the thick of self-harm, I'll try and find out things that they like, things that they would much rather have on their skin, and order, specific types of imagery and tattoos. But yeah, the tattoo markers are pretty amazing. If you scrub them really, really hard, within a day or two, they'll come off. But if you're just like washing like normal, they'll last for a week or two. Yeah, someone is mentioning just some relatively creative clients that use all kinds of things for self-harm. And that's goes back to sort of the idea of cleanliness and hygiene. Like, clients are super resourceful. If they have this idea, if they have this plan, they're going to do what they can to figure it out. But that's where psychoeducation on, like, let's think about the object that you're using, the hygiene of the what you're using, like the long-term impact biologically of like extreme sour or hot sauce, like you're burning yourself. And like what that could lead to and how that might impact things that they enjoy that they're not thinking about in that moment. I think the last one is henna. Let's talk about henna. I think it's a great resource. It satisfies so many urges. It satisfies like pressure on your skin. It satisfies having something that dries in like a way that cracks and then can be picked off, sort of like a scab. It leaves behind a mark and it lasts for a really long time. It comes in sort of that red, copper, pink color. What I want to caution you about henna, especially if you're going to have it in your office or recommend it to other clients, is make sure you don't have and you're not referring them to typical henna applicators, because it's typically a plastic bottle with like a long metal kind of pointy tip, which honestly, if you tried hard enough, could cause harm. So there's cones made of paper, and like you could say, sure, they're going to use the paper and get paper cuts. Yes, we can't minimize, we're not going to be able to eliminate harm. We can just educate them on resources that they can use instead of harm in general, but also if we're just trying to replace the behavior, because it's unrealistic to say you should not be self-harming while we figure out what's driving this behavior and like how to address those underlying behaviors. You need to stop. They're not just going to be able to stop. This is like a pattern of behavior. So trying to find alternatives that satisfy that urge, but don't cause physical harm, is going to be a good like step down before you're like fully addressing things. So just be careful about that. Paper cones are much more highly recommended. You want to be brief in your initial intervention. Same idea that I was just talking about. When a person's in crisis, cognition is less flexible, right? It's just a cloud. It's a mess up there. They don't have access to those typical ways of coping. And it's not really the time to come up with solutions to their problems, to problem solve. Asking a person in crisis to problem solve and like consider consequences, again, that's where deliberation data and means restriction comes in. You're setting them up for failure. And so brief interventions is just options other than self-injurious behavior. And if you can have those alternative actions or activities determined by the client and documented in advance, super awesome. Also contributes to their sense of agency and internal locus of control. You want to empower them. Part of, for a lot of clients, self-harm is like taking control in some aspect of their life. And some people might say the control that you've decided to use is to like harm yourself. I know for a lot of people, it might not make sense. For that person, it's the thought that came to them, and it's the only way they feel like they can exercise control. So any opportunity that you can give them, to exercise control in other ways is going to be helpful. I'm a big fan of grounding and self-soothing because oftentimes my clients are stuck in their thoughts. Those thoughts might be pulling them into the past, might be ruminating on something that just recently happened, or might be fear and anticipation of something that may never happen. So if I can kind of ground them in where they are with the things that are surrounding them as a skill, I think that's a great place to start. Cognitive skills can come later. So I like to break it down into the five senses, and I might just prompt them about what they do to feel better when they don't feel great. And typically, prioritizes into two or three of the five senses. Maybe they are a sight person. They like to watch movies when they're upset, take or look at pictures. They're social media scrollers. There's been some really cool, this isn't a recent thing, but something that was brought to my attention that I was talking to a high school about 2 weeks ago is like live action animal videos, like a lot of aquariums and zoos and other like animal rehabilitation centers have live feed of their animals, and that can be really soothing if you're more of a visual person. Again, back to the lights, like having any control over the darkness or the color of lights around you. Sound might be playlists. Maybe we're creating playlists in session. Sound machines that helps maybe them relax, fall asleep. Guided meditation, Insight Timer is a great app for that. That'll be on my slide, my app slide. Are they a touch person? Right? Soft materials, holding a blanket, things that squish, temperature shifts. So something really hot, really cold, run your hands under cold water, having a heat pack. Smell and taste, obviously the sour thing can be taken to exponentially unhealthy levels. But I do often have things like regular warhead gum, fireballs, Hershey Kisses, being mindful of dietary restrictions and dietary needs in my office, and then scented candles, someone said scented lotions, flowers, familiar foods, like smells and tastes that can be nostalgic can be really helpful. But I feel like that's always a great place to start. And I have something that I do with my clients called coping kits. So I get most of this stuff from the local dollar store. These are just some images of like some hauls that I've used. So it's notebooks, fun dip, things that glow, things that smell, things that are fuzzy, lights, things you can write sort of like positive reframes on. On the left side, top, there's an image of like three, looks like little finger protectors. That's what they are. They're like rubber. I have some clients who, when they're upset, whether it's the intention to like break skin, draw blood, whatever, they dig their nails into their hands, and it might just leave like little welts, but it might break skin. Like they may actually cause harm. And so having those finger protectors is again a way to allow them to start building mindfulness, building insight into, oh, when I'm in the situation, when I'm feeling stressed out, I clamp my hands together because I'm talking about this in therapy and I'm trying to figure out what I do when I'm overwhelmed. But they're protected. So I'm not causing harm, but I'm bringing attention to this action. And then I can release, we can do some progressive muscle relaxation. We can release my hands. We can do something else with them. And while I'm working on that, because that's not going to happen overnight, and I'm going to tell them that, and I'm not expecting them to do that, and we're setting up realistic expectations, they are staying protected. So they're kind of like, they're still able to do what they have been doing, what their urge is to do, but they're not causing harm. And they're building insight and mindfulness to release that. And they're learning skills and techniques to like reduce/eliminate the possibility that happens again. So that's sort of the framework of how I think about these things. I love everybody's excitement about coping kits. They're my favorite. And when we go to schools and stuff with James's Warriors, we bring a lot of coping kit stuff and we'll play games with them and they love it. Yes. So someone's saying they make them at school. That's a good point to bring them home. I usually give them a basket to bring everything home. You see a bowl in one of them, or there's a basket in there as well. We talk after we make the coping kit and sort of play a game of like, which of the 5 senses do you think this is? And also like, would you use this or not? I'm not just like giving them these things. I'm making sure I'm giving them the things that tap into what they would use. We discuss where in their home, but just like where in their life do they anticipate being in the most stress and needing coping kit materials. So that might be a nightstand, that might be where they do their homework, that might be in a car where they're driving to and from places that are stressful, that might be in their backpack, in their purse, in their locker. And these are small things. These are things that like you could carry around that someone's not going to be like, oh, you have your coping kit today. Kids are worried about that. These are just like fun items that you can utilize and store in areas where it's within reach. Again, we're not expecting them in those moments to like pull a cognitive skill, identify the coping, like the toolkit, pick one, implement it, and implement it effectively. Sometimes you just need something to squeeze. So I'm a big fan of journaling. You'll see journals and pens, scented pencils and stuff in the coping kit slides. Not everybody wants to journal. I totally get that. I can empathize with that. A lot of my clients are coming from school, they're coming from work. They don't want to write anything, and they certainly don't want to write about their own feelings. That feels extremely difficult. And so, blackout poetry is an amazing alternative that a lot of my clients find to be extremely helpful. You're taking text that exists that you don't care about anymore, a magazine, a newspaper, an old book that you can mark up. It's someone else's writing. It's about someone else. It's not about your experience, but you black out the words you don't want and leave the words that you do. You can leave a single word. You can leave a single letter. You can find letters in all of the words to make one word, or you can make a beautiful poem like this person did. They wrote, I had been treading water, exploring the depths, following all the way down. It was a cold and lonely place. Then it occurred to me. Such power. The sun sends a dazzling band of light across the sea, a shining sword in the water. It allows them to tap into both their, like, what might be described as negative feelings and also provides some hope. If they don't want hope and they just need to, like, sit in their feelings, great. If they don't want to sit in their feelings and they only want to be hopeful, great. What's awesome about this is that blackout poetry is a community of individuals. There are forums, there are poetry jams, there are blackout poets all over the place. And so this also allows for them to tap into community that whether they are actively participating in or just like consuming a place that they might connect to people and could, be an opportunity for them to like explore a passion or make friends. And so I'm a huge fan of blackout poetry, and I always have magazines and things that they can use and take home with them for collaging and art and boards and all that stuff, but they can use it for blackout poetry too. So if you have a collection of books or magazines or newspaper clippings, you could do that in session with them. And I'm a big fan of, bringing all this stuff into session and doing it yourself. So it doesn't stigmatize it. It doesn't feel like a quote unquote therapy tool or a coping tool. These are just activities that we can do when we don't feel great and we want to feel better. Here's the app slide. Calm Harm is the app that I was talking about earlier that checks in with you after you've gone through an activity to see how you're doing, if it was effective, and then gives you an opportunity to do more. This is my most recommended tried and true BF therapy app for self-harm. It uses comfort, distraction, expression, release, and breathing. When an urge to self-harm presents itself, it does have a mood and effectiveness tracker, and then, as most apps do, like a list of contacts if needing support. Insight Timer has some free options, also some subscription options for guided meditation exercises. Calm Harm is free. WhatsApp is also completely free and more just like CBT, ACT techniques for like a broad range of presenting concerns. ThinkLadder is subscription based, but is very CBT based. And I was sort of raised in CBT. I have a lot of other evidence-based exposure, but I do conceptualize a lot of things and like take action in a CBT way as a therapist. And so ThinkLadder is a great recommended app for me, and we can do a lot of work together in session about distorted beliefs and insights or like positive reframes that you can use to challenge those negative beliefs and then redirect your automatic thoughts. And it's expansive in the distorted beliefs it starts with, and it kind of creates a story of like, this is this distorted belief you have, and it gives you like hundreds of options that you can connect to, and then what's the reframe, how to challenge it, and then you can sort of have those things as backgrounds of your phone or prompted as a reminder. So if you're a CBT therapist, I think ThinkLadder is great. And then Flowly is virtual reality biofeedback for anxiety, but also for chronic pain. You don't have to use like the virtual reality goggles. I have them like right up here in the corner of my home office. I have another set at my office, but basically it's using heart rate variability by tracking your pulse on your finger, or if you are like going for the kit, they'll have like a pulsometer. And you are actively in like causing change and interacting with the visual and auditory scape of the scene. And there's dozens and dozens and dozens of options for being in the mountains or being in the sky or being in the ocean or just like walking along a snowy winter like walkway with a fire. So many options. And if you want, there is some prompting from an individual who's kind of like walking you through a guided meditation, very personalized. You can turn that off. I don't really like to be prompted like that by someone who one of my teenagers would certainly say is like using a therapy voice. So I can just turn it off and I can watch the sort of like inhale, exhale prompt. I've now learned my sort of inhale, exhale rate, which is most effective for calming down. I've had to use that in other circumstances, even when I don't have the app accessible to me. So highly recommend Insight Timer. Someone asked if we're going to have another 10-minute break. Yes, we will shortly. And then we'll kind of head into the third aspect of this. We can actually, let's just take it now because then we'll go into safety planning. So it's 12:01. Let's come back. Well, it's 12:02 now. Let's come back at 12:12. And then we'll get into the safety planning of it all. Again, if you have any questions, put them in the chat. And then we'll probably save a lot of those for the end. But so as mentioned before, right? Safety planning is including identification of thoughts, feelings, experiences, hopefully prior to the crisis, preparation, so that we can figure out the signals, better prepare, listing those effective actions that they've found helpful in distracting and self-soothing. We want to make sure, like everything else, it's feasible, it's accessible, giving them options, giving them a sense of control. And in terms of that empowerment, making it personal, listing things that they're going to actually do, helping them trust their knowledge. They are the expert on themselves, right? A professor in grad school always said, like, you're an expert in this field, but they are an expert on them. So I use that sometimes with clients and, being an expert on their own experiences and what helps them best. So what to include, and you'll see this on the safety plan that you will have after this training. So it's not going to be visualized here, it's just going to be written out verbally, but differentiating levels of risk for both suicidal ideation and NSSI. I have two separate sections, and that will include historical and active experiences. Internal strengths, one thing worth living for, that sort of taps into DBT experience. Short-term goals, long-term aspirations, because you don't just want to do like what's worth living for, because I think a lot of clients tend to think future forward. And that is something that might take a lot of time to get to. You want short-term goals that they can easily reach, that are accessible to them so they can feel successful as well. People with whom they can discuss their distress and thoughts with, feel heard and supported. School resources, if age appropriate, I always identify in schools like which teacher or school staff member coach is typically in the school and is willing to, support the client if they just need a little bit of time out of class or time processing things during lunch, and caregiver commitments. So removing means, supporting the safety plan, that's all in the document that you will have, and that addresses one of the questions in chat during break. Some people bring up contracts for safety. A no contract, like a no suicide contract and or a safety plan, when we think about liability and court findings, is considered an event which takes place at a particular time, whereas assessment of a client is a process, and it's the assessment that needs to be documented consistently. So yes, for protection against liability, that ongoing assessment of risk is necessary, and that taps into an earlier question of like, how long will you always document in the note that you assess for risk and what they said? Yes, you do. That will be your best protection against liability. Discuss the likelihood they'll actively use the coping skills and refrain from engaging in self-harm between the session and the next. You also want to explore those perceived barriers as well. As I mentioned before, that increase in sessions, right? If they're not being seen weekly, there has to be a discussion about the importance of checking in more frequently, building their coping repertoire, and practicing effective skills. Even during a consult, if someone mentions that they're being referred to me or coming to me for suicidal ideation or urges to self-harm, I will say I require weekly sessions. And if they don't feel comfortable with that, or for whatever reason, that is not possible for them within my schedule or within other reasons, then it's not a client that I feel comfortable taking on. And when we think about contracts for safety, it's really hard for the client to imagine, much more difficult to agree. They'll never act on the urge ever again. So again, when we're thinking about those replacement therapy techniques, we're thinking about things that are setting them up for long-term success, even a week, even saying like, do you feel comfortable like trying to abstain from self-injurious behaviors between this session and our next session in a few days? That might still feel impossible, but it's much more attainable. And ultimately, we're trying to set our clients up for success, because if they shoot for the moon and they don't accomplish any of that, that's going to contribute to their feelings of anxiety and depression, and likely just cycle into these thoughts and urges. Okay, taps into reminder time and bringing in the caregiver if we're working with minors. So early on during the confidentiality spiel of an intake, a client might nod, confirm understanding of the limits, but later forget the conversation entirely, feign misunderstanding, say, oh, well, I don't remember you saying that they were going to have to come in. I thought maybe they could. They've said things like, they're going to freak out, they're going to send me away. Could be their actual experience, could be an experience they saw on TV. They're going to hover over me and it's going to be so annoying. That goes back really early on in the training into that repeat questioning. I won't be able to do anything without them asking me a million questions. And sure, hear them, validate them, bring this up with the caregiver. It's important. But you can say something when you're prompting them about this reminder, like, okay, well, we have some time left. Let's decide how we're going to share the information with whomever is outside, so we're all on the same page before you leave. And then again, give them control. Work on empowering them. Let them decide how they're going to invite the caregiver in. Here are the options. I, as the therapist, can bring the caregiver in. I can stay in the room and I can share the information. We'll have already talked about how I'm going to do that. We're going to come up with like a code word or a code move that lets me know, or I can let the client know that like I need to tag in or they want to tag in. The client can choose to be in the office or not. We have a shared work area. We have a waiting room. There are areas for them to be there, but not in there. Totally up to the client. Also, I can bring the caregiver in, stay in the room, and I can be quiet, super supportive. I can just listen to them, share the information. They understand that I'm going to sort of do a summary and make sure everything was communicated as necessary. But also case dependent. The client can get the caregiver, share the information, and I can be just outside the room. I want to make sure that I trust the caregiver to receive that information and respond in a way that's neutral to helpful. If it's going to be ineffective, I'm not even going to provide that option. And again, I'm going to come back in and say, how did that go? Let's talk about it. Here are the things I want to make sure we're covered before we end the session. But I want to give them as much control as possible. When the caregiver comes in the room, you have to be ready to validate big feelings, big reactions. This is tough stuff. Be honest about your experience with the population. I think for me, that feels like it sort of calms them down a little bit. Like, I'm a person who works with this every day. I'm ready to continue working with this client. Or if you're not feeling comfortable, or you don't have the capability or the space, like it could be emotional resources that you are working with too many other high risk clients, and like you've reached your capacity. Even people who specialize in it, like we have only so much space for this. You just don't feel comfortable working with it and you want to refer out. I think it's so important that you don't see that as a failure, but ultimately the best way for you to possibly support that client is to really reflect on that and make a referral. There's nothing wrong with that. But let them know, yeah, a referral is going to be appropriate. I don't have the time. This isn't really my specialty. I know this other person. This might be a better fit for an intensive outpatient unit or a day treatment program. Really empower them to see themselves as a support to the client. And I always have a list that is online, like it's a Word document, it could be emailed, but it can be printed out and handed to them of nearby resources. That's the helpline number I've mentioned, any higher levels of care, for me, the stabilization center, for Windsor-Gatona, Westchester Medical Center. And it has sort of like the admitting numbers and then any contact information and addresses that they might need, just so that they don't have to worry about looking that stuff up. I have it accessible. It's right there. So I recommend doing that as well. So after I've shared the information with them, or after they've shared it, whether I've been in the room or not, here's sort of the checklist that I go through in my mind. Want to make sure that all the information gathered using the questions we've already covered has been conveyed to the caregiver prior to leaving the session. I'm going to review the safety plan and add any helpful insight and coping skills that they might have that the client hadn't thought of or mentioned earlier. Right? They might see things in the client that indicate that the client is struggling, or might prompt them to think, oh, things are not going well. The client might not even realize that they're doing. And so having them there can be really helpful. Discussing coping skills that were discussed, practice with the client in session so that the caregivers are aware of them and can also prompt the client if overwhelmed between sessions. Sometimes the client's, again, so overwhelmed and cloudy in their crisis, they're not going to be prompting themselves to reach these skills. They're just in it. And so a caregiver might be able to identify they need it, and they know the skills, they have the plan, they can prompt them. And then if it's a client that you've been seeing every other week and things have escalated, advocating for and then insisting with the caregiver for an increase in sessions so that they can be monitored on at least a weekly basis. It's important to think about between sessions too, like validate for clients and their caregivers. It is hard to talk about tough stuff when I'm not in the room mediating that conversation. If the client feels comfortable using their words, they don't have to provide every detail. This like goes back to sort of this helicoptering, this like repeat questioning, the constant feeling of checking in, and the adolescent feeling like it's overwhelming, it might be annoying. If verbal communication feels effective, great. Let's discuss language that we can use to ask about how it's going and language to communicate satisfactorily that things are going okay enough that like a higher level of care doesn't need to be accessed in that moment. Like, is it a crisis or not? How do we have that conversation? And if verbal communication is not where it's at, plenty of nonverbal ways to ask for support or indicate where you're at. So just gave an example of something that I've done with clients in the past. A lot of my female clients have like a variety of different scrunchies, using different colored scrunchies on the outside of their doorknob to inform the family that they have ideation and it's managed. They have ideation and they love some company. Please knock on the door. Please like wait for permission to come in. I will let you know maybe by color if I want you to like talk to me and ask me about things or prompt me, or if I'm okay, I just need proximity to someone supportive. Just like come hang out with me on the couch or in my room. Or, and you don't really want to have a scrunchy color for this because this is more of a need to address this now. But if it's just under the crisis, like I am really thinking about hurting myself, I need immediate support. I talk about caregivers and their perception that sometimes ideation is understood as manipulation a lot because it comes up a lot in my work within families that are high risk. So I try and communicate to them that what feels like manipulation, and in this case, this might be a caregiver saying, no, you can't do this, or there's a consequence for your behavior. And the client says, well, then I'm just going to kill myself. If you don't let me do this, I'm going to hurt myself. And that is like, well, she's just manipulating me. They're just manipulating me. And I try to reframe for them. That's often deep emotional dysregulation. It's not a calculated power move. Often. I'm not saying never, but I do not want to like diminish most experiences of suicidal ideation or urges to self-harm as manipulation or calculation. So if caregivers are viewing this behavior, this disclosure as coercive, they may over accommodate, which sort of enables. They might swing into rigid control, which is just likely going to be ineffective, or disengage, also not ideal. You don't want to leave the client in that place alone. These children are often just trying to externalize unbearable distress. And so I might say something like, your child doesn't want to control you. They just want to feel in control of something. And we want to help caregivers see behavior as a symptom, not a strategy. So by helping caregivers reframe the narrative and see that they're being called to co-regulate, you can prompt them to review the safety plan, just sit with them and breathe, do some behavioral activation, maybe go for a walk, and then how you proceed. So if past statements of, well, I'm just going to kill myself, have earned them attention, relief, or concessions, the adolescent is learning that crisis equals connection. And so we want to prompt the caregivers between sessions to validate the emotion and not the behavior. So you can acknowledge pain without rewarding the outburst, and that still keeps connection open without enabling anything. So a specific prompt you could help a caregiver utilize in between would be, I can see that you're really upset right now. I feel like this is a lot. So you're basically working with them on active listening. And you want to set a clear safety message that reinforces that threats lead to care and structure, not panic or bargaining. So when you say things about hurting yourself, I take that very seriously. That means I'll be reaching out to get you support because your safety matters more than anything. So like you're being present as a provider, but you're also letting them know like this is a serious statement to make. And because I love you and want to protect you, I will be making calls to ensure that you are safe. Because sometimes adolescents will push and be like, yeah, I say this and nothing happens. And I also make this very clear in session. Like, I will take that statement so seriously, and I will encourage caregiver, partner, family member to do the same. Like, if you make a disclosure like this, especially if it's active, we're going to move forward and ensure that you're safe. And then hold the boundary with warmth. Prevents reinforcement of coercive loops while keeping attachment intact. Saying something like, I still can't change the decision I made. I'm sorry. Like the consequence stands. You still can't go out with your partner. You're not going to this party this weekend. I'm not changing my decision. I love you. I'm here with you in this feeling. My answer has not changed. So sort of working with them on how to navigate that, because that does come up a lot. And then we have a slide for documentation. We've covered this a little bit, but every progress note I have has a risk assessment section. So it says both, like my safety plan for suicidal ideation and for self-injurious behaviors. I have little boxes that I can check off for ideation, intent, plan, or attempt, or not applicable. And then if I check on it, it opens up into a text box. And then I can say that, history of suicidal ideation, no recent ideation reported, or recent urges to self-harm reported, no plan or intent, conducted a risk assessment, reviewed safety plan, gave a copy to client prior to the end of session. I am saying that I did all the things, that this is what's historical. I will leave that there. I'll sort of like pre-populate the note so that there's always just going to be something that says history of suicidal ideation, history of urges to self-harm. Then I will say active, yes or no. Then I'll say risk assessment, did. Reviewed safety plan, like not actively suicidal, no active urges to self-harm. But if recent, then reviewed safety plan, talked about support, came up with another coping skill, something like that. And I will reassess it every session and document some more. And I tell my clients that, because part of their fear after the disclosure is like, okay, well, I did it. I never have to do this again. Or do I have to keep doing this? Like, am I going to have to do this again? And so I'm transparent about it. Yes, if you make that statement to me, then I'm going to ask every day until for at least 3 months. And that sort of clinic parameters that live inside of me, you are stable and have not had any recent or active ideation or urges to self-harm. And then I might not ask about it specifically, but I'll always document that there has been a history and that there's been no new reported ideation or urges. And then if it happens once again, that like 3 months clock starts again from zero. But I'll say something like completed a risk assessment, denied recent or active suicidal ideation or urges to self-harm, endorse recent passive ideation without intent or plan. I always have a record of the safety plan on file so that I can print it out or email it to them or send it to their client portal. I also am documenting not just on the safety plan document itself, but when there is safety planning done in the session, that the caregivers were updated, that they reviewed the safety plan, that they received a copy, and that they were provided psychoeducation on means restriction. And whether or not they were responsive to it, like they were updated, they acknowledged, understanding, they received the safety plan to which they were receptive, they were provided psychoeducation on means restriction and agreed to get a lockbox or lock up all sharps or medication, whatever it is. So you're not only documenting what you did, but how they responded to it. Because again, if for whatever reason something happens and you get, involved forensically, that information is going to be really important for your liability protection. Beyond these brief interventions, the therapeutic interventions I lean on most often are family therapy, CBT, and DBT. And we've kind of already explored why. In family therapy, especially if it's minors, you're validating those emotional experiences, you're building language, and you're sort of working on tolerance of difficult stuff. You've got intrusive ideation, automatic thoughts, cognitive reframes, and thought challenging within CBT. And then you've got your 4 modules in dialectical behavioral therapy: mindfulness, emotion regulation, interpersonal effectiveness, and distress tolerance. And so I'm going to talk specifically about a DBT intervention that I utilize to track ideation and urges with my clients, called a diary card. This was designed for individuals at a high risk for suicide, ideation, urges. It's important to recognize and to communicate to the client. Those things are going to fluctuate, right? Weekly, daily, sometimes hourly. In addition, there may be periods of time, weeks or months, without any suicidal thoughts, only to have something reemerge at a later point. So I do have clients complete the diary card, especially within that like 3 month window. That includes daily ratings and it allows for routine monitoring at the start of every session. And that's critical for me to be able to intervene if something is high. Maybe they're not going to automatically bring it up, but this is sort of, again, making it a permissible part of conversation, normalizing it, as well as continuing to build insight into what increases and decreases those urges and what coping skills might be effective. This is what a diary card looks like. This is a very, very simple diary card. If you were to look up diary card options like DBT diary cards, sometimes they have dozens of columns. That is very overwhelming to me, to my clients, to their families. We're working small, short, reasonable, accomplishable steps. We're just building insight and keeping track of things. So from the day of my session to the day of the next session, I set it up. If we're addressing NSSI, I have an urgent action section. Did they have an urge? Did they take action? It could be an X, it could be a sticker, it could be a color. We could come up with our own language if they're worried someone's going to see it and understand what it is. Maybe we're building insight on how they feel and prompts it. So like mad, sad, are they afraid, feeling shameful, happy? Does it happen sometimes when they're feeling good? And what skills did they use? So, did this client use blackout poetry? Did it help? Emotions could be people, places, things. You could personalize a copy of this, and the copy will be included in the PowerPoint that you receive after the presentation, so you'll be able to keep this. But also, if you looked at any DBT manual or just looked up DBT diary cards, you'll see an expansive set of examples. It's really up to you to tailor it, but I find that like 3 or 4 max columns is going to be what they find attainable. They're going to do it at the end of the day, or first thing in the morning, or they're going to come into session with it incomplete, and you're going to say, okay, great, let's go over it together. Let's use this as a jump off point for conversation. When do you remember? Do you remember? Was there a time when you had any urges this past week? What was going on? What did you do? You know what I mean? It allows just for tracking. It allows for tracking when things come up and building insight into that, but it also allows for tracking success. And when they maybe have an intrusive thought or an urge and they take action on it for the first time in a while and they feel like they're back to square one, you have this collection of tracking for months where they were able to manage these thoughts and feelings and urges and choose a different path. So it allows for you to, reframe that feeling of failure for them. For future sessions, can't effectively intervene unless we know that risk is present. So I do tell them on the day of disclosure, every subsequent session, I'm going to do that risk assessment. I already mentioned that. And also if they're stable, it's not something that has to take up the whole session. Likely after a disclosure, like the whole session, and maybe some subsequent sessions are more focused on the disclosure. Afterward, a risk assessment can be very simple. Have you had any suicidal thoughts since our last session? In the last week, have you had any urges to self-harm? Like, did you engage in any cutting behaviors since we last met? Yes, no. And then based on that, you can ask some more questions. But like, if no, okay, that's amazing. What do you think allowed for an entire week of like no action? Or when there were urges, what did you do to hold off on the action? What actions did you take instead of the self-harm behavior? So you're learning, you're building insight, but it doesn't have to be this entire session every time. And I think sometimes because of media, because of what they've read, because of what friends might have said, they have this idea of what it might look like, and that might contribute to fear and sharing in the first place. So by giving them the psychoeducation, you're sort of letting them know, yeah, of course I'm going to ask about this. I want to make sure you're safe. And also, this is just like one topic of conversation in a wide variety of topics we're going to cover every time we meet. But if they do say yes, then you can pull up the safety plan, assess effectiveness, might be an opportunity to add to their toolbox of techniques. It's just an opportunity. So someone said, what about adults? This is what I do with adults. Ultimately, I want clients leaving the office feeling safe and remaining safe. So when I meet an adult or when one of my minors turns 18, I'm discussing the benefits of obtaining assigned consent to reach out in times of need to a supportive individual in their lives in crisis. Also, if they miss an appointment, because for me, that can feel like a crisis. When I'm actively worried about my clients being safe, if a client no show, no calls, and that's weird for them, I could be in full panic. If I haven't heard from a client who said they were like gonna get back to me about something and it's been a week, like I have occasionally checked the obituary section. It's to that level of high risk at times. And so it can be helpful both for the client, also for liability, but also for our sanity as providers working in this population, that I can reach out to a caregiver, a partner, a peer that's close to them, that lives with them, that has access to them, to say, hey, I was supposed to have an appointment with client today. It's they're not here. It's not typical of them to miss an appointment and not get in touch with me. Do you know where they are? Like, can you try and reach them? I just want to make sure everything's okay. Or hey, I'm with client and they're having a really hard time and they're not sure that they're feeling safe enough to like get in their car and drive home. Are you nearby? Like, could you come and like ride with them or pick them up? Or it gives a supportive base. And again, ethically and legally, it's covering you to support the client. And I'm reframing that as like, you don't need to do this by yourself just because you're a quote unquote adult and you should be figuring out how to do this, like making it on your own. Let's find one person. Let's identify one person. We're doing that for the safety plan anyway. Can we get a consent for them on file so that I can check in if needed? And in that, I don't have to ask in that moment if it's a crisis, like, ooh, I don't feel really great about you driving home. There's nothing I can do about that because you're 18 or older. Could I get a consent to reach out to this person? Like, I want to make sure I'm covered while I'm protecting you. That's not the moment. The moment is like, hey, as part of my practice policy, I have a consent on file for a trusted individual in your life in case I need to get a hold of you and can't, unless, I am worried about you in between sessions and I'm just checking in and I can't reach you, or if you're with me and we just need some extra support so that you don't have to feel like you have to do it on your own and we're not like figuring that out in the moment. And so I just kind of make it pretty normalized as part of my process. And I rarely have resistance to the consent. I've never really had resistance. I've had people like wonder about it. But yeah, I have consent on file for a supportive person for every client that I see, regardless of their age. This ideation, these urges can be extremely overwhelming, the most overwhelming. And sometimes when they have these thoughts, they feel like they can't get out of bed. So I always sort of, toward the end of these presentations, walk through how I might prompt a client out of bed if they're finding themselves that overwhelmed. So I start with some visualization. I just have them think about getting out of bed, standing up, sitting up successfully, walking around their room. For sort of developing scripts and practicing self-talk. Like, I've gotten out of bed a million times before. I can do this. Just like one step. And I'm engaging in some behavioral activation, wiggling their toes, getting the blood flowing, doing some progressive muscle relaxation, focused on sort of the calf or thigh muscles, thinking of a reward they're going to receive for getting out of bed. And we'll do that together. Like maybe it's eating a delicious breakfast. Maybe the cooking part is the fun part. Maybe someone at home can make that breakfast for you. You can even smell it and it's like getting your taste buds ready. Maybe you want to just like watch a show before you go to work or go to school. Maybe there's a pet that's out there that's cuddly and fluffy and happy to see you no matter what. And you just want that sort of like pet therapy. Then have them hang their legs over the side of the bed. So this might feel slow, step by step, but again, like small, accomplishable goals. Let their feet touch the ground, grounding in a real way, more self-talk. Okay, one step at a time. I can do this. I did this. I'm halfway out of bed. I'm just going to this reward, right? Like I'm standing up, I'm going to the reward. Maybe that's all that I do. Maybe I stand up. Maybe I change my clothes, try for a shower, brush my teeth, and feel like I have to get back in bed for a little bit. Or I might encourage them to lay on the couch. If like bed is where the feeling is kind of stuck, lay down. That's fine. Change your pajamas into new pajamas. But maybe a comfy chair or a couch. And then be so proud. Like there's can be so negative about the small steps that they take because maybe they're not getting the reinforcement from other people in their life. And if they are, it's not landing, it's not internalizing. And so by kind of going through this self-talk, coming up with it with you, practicing it with you, you're sort of modeling this praise, this acknowledgement of effort when for whatever reason, especially if they're in sort of emotional and physical pain, can feel like chronic pain individuals use spoons as sort of an objective measure of how they feel and how many spoons they have left. Like it could be the rest of the gas in their tank. And they used it, like they put in effort, they tried to get out of bed. And so small steps are still a really big deal, and reframing that for them, I think, is really important. Now, you have just sat through a 3-hour presentation, and you could be going back to work after this to sit for many more hours with clients who may certainly be talking about things like this. We are the holders of this space, right? We keep these feelings, but we need to be careful and be mindful of ourselves as well. So clinicians often report when working with this population experiencing intense negative emotions, includes fear, guilt, anxiety, self-doubt, hopelessness, frustration. I felt them all. I validate that for you. And the weight of quick decisions made around this topic within a single session can be really heavy. It's normal to second guess yourself at times because no scenario is exactly the same. I've been doing this for over a decade and it's what I do. It's what I love to do. I feel like I'm good at it. And I'm still nervous sometimes and call a colleague and say, listen, this is what happened. This is what I did. Can you just tell me that I did a good job or that I did it right? Did I forget anything? Sometimes you just need that because no situation is exactly the same. And this is life or death at times. And so you just need to be open to this is permission for support, right? That can be peer consult groups, that could be supervision, that could be being in your own therapy to process this, right? They always use the example of like put the oxygen mask on the plane on yourself first before you put it on the person next to you. Super important that we take care of ourselves. And I really appreciate you guys all being here and being so engaged and interactive with me. I know we have a little bit of time for questions before I turn it over to wrap up, but just to be here today, some so early in the morning, to engage in this work, but also keep following up. There's always going to be research on therapeutic assessments and interventions that are going to be effective with this population. We're going to learn more about models of pain. I consult on this topic, so if anybody has more specific questions, you can reach out through our website, through me. But let's take some time for any questions, I so appreciate all of your positive feedback. Does anybody, I'm looking at the chat, does anybody have any specific questions? We have a little less than 10 minutes. So I want to make sure to answer things. I think, let's see here. How do I handle situations where an adult might not have a trusted individual that I can coordinate with? Yeah, and maybe part of that is identifying that that person doesn't exist and that that's a barrier to safety and working to carve that out into their life. And if it's not a trusted individual that I can call, then making sure that they're aware of the local resources. Again, I am really lucky to be in an area that, like, within 30 minutes and open 24/7 talk or text, which, like, some of my clients will pick up the phone and call anybody, but they'll text, so like that's accessible too. They will, I'm making sure that they're aware of the resources. I'm happy to collaborate and sort of connect clients to the resources. So if the helpline is sort of the supportive individual while we're working on identifying areas of their life that they could potentially develop or find or identify another person that they maybe didn't think about as that supportive person, but could serve as that person, and maybe having conversations that might spark and encourage some role playing and conversations in session about bringing this topic up with other people in their life that they're not sure if they can trust to sort of establish that individual in their life. So it's just it's a great question. It's just grounds for conversation with the client. So question about the handout, you're gonna get a copy of this entire PowerPoint, and I have a safety plan that's built out that you will get a PDF version of. So that'll be something too. Love all the positive feedback. Recommendations on working with a parent who downplays their child's passive suicidal ideation. Super unfortunate and just requires, listen, I will be upfront and transparent about the importance of taking these things seriously and what can happen if they don't. And if it gets to the point where it's neglectful, it might be a mandated reporter call to ensure that the client is surrounded by individuals that are going to take it seriously and take action to keep them alive. But might also be an opportunity, not just in the client's session, because I don't want to take away their time, and it's an adolescent, so I'm going to ask them if they want to be present for this conversation or not, but certainly encouraging the parent to schedule a parent-only session or some extra family sessions, just so that you are like doing your best to communicate the urgency of these thoughts and urges, giving them the psychoeducation, working with them on the safety plan. And if that is the case, it is so important that you so clearly document all of these things, and that they weren't receptive or it felt like they were downplaying. And so you recommended, like, you ensured that they had all of this information. You gave them a copy of the safety plan. You encouraged them / scheduled a parent only session. Just to say, like, you are doing all that you can. You can't force a person to think about something in a different way. You can only provide them with the information that helps them to reframe or re-understand the information. And so I would do all those things and I would document it. Yeah, they're putting a form in there that you need to fill it out to get the CE credits. Someone said, I'm assuming that would apply to informing adult children of elderly struggling with SI. Yeah, it would be if you're talking about the 18 plus consent for sure. Um, well, I mean, to be frank, my oldest client is 40. I really am working with sort of like high school to like 30s, mid 30s, because I see deaf clients. I see them of any age. I'm just providing accessibility to deaf clients who are looking for mental health treatment. So that's where like some of my older, and for me, older is like late 30s, early 40s. But yeah, I would get a consent from them too. It's really just part of my practice policies. And if they have any questions or confusion about it, I'm happy to explain it. Someone said, do you typically respond to the hospital or inpatient treatment center with your client in crisis, or do you wait till the client is stabilized and released? Um, I don't know that I understand. Do you typically respond to the hospital or inpatient treatment center with my client? I so to my understanding, I'll answer. I typically can help coordinate um client admission into a higher level of care. I have been requested to by family and clients to be in the emergency room or waiting area with the client just for their support because that process can be very overwhelming. I've done that. You certainly don't have to. I chose to do that. Um, and then it's typically the rule is that they disconnect from my care while they are in the higher level of care. They do not continue meeting with me. I have had some adolescents that were high risk but weren't in the inpatient unit for mental health. They were in the like child unit for medical care because they had a comorbid eating disorder and they were not stabilized there, so they could then not be admitted to the mental health aspect of the inpatient unit. So I was able to continue with like daily sessions with her prior to being admitted into the mental health inpatient unit. And then the coordination of care afterward is the family signs a release to let the hospital know that they have a therapist at home, that there's appointments set up, that I will be seeing the client on this particular day, just for continuity of care. And yeah, that's how I proceed. So it sounds like I answered your question. Um, what do you recommend for clients who use suicidal ideation as a means to be admitted to the hospital in order to get out of their unstable home environment? I guess that would just prompt a lot more questions for me. Super case by case specific. I'd want to know what the instability of the home environment is, what the goal is. Like, are there alternatives like respite or other homes or resources in the community that you could use and connect them to rather than being in the hospital? If they aren't truly experiencing suicidal ideation. If they are, then the hospital for that moment is the best place for them.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.